Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Beta-lactam allergies in HIV patients. Drugs and hypersensitivity reactions are more common in general in HIV patients overall. So in allergic reactions, they're mainly immediate or delayed reactions. And based on the Gjellenkloem's classifications, they are type 1 to type 4. Type 1 reactions that we commonly come across are IgE-mediated hives or angioedema or anaphylactic type reactions. And type 4 reactions are delayed T-cell mediated reactions. They could be mild or severe. So seroallergic reactions, the common examples are flushing that you see with vancomycin, that's called red man syndrome, and there could be idiosyncratic reactions. And not everything that is documented as allergy is an allergic reaction, which is important to remember. Okay, how do we characterize an allergic reaction? So most of the hypersensitivity reactions do present with some type of rash, and it's important to us understand what kind of reaction which guides in the management of these patients appropriately. So let's begin with a case. Here is a 26-year-old male with HIV, presents with sore throat, fever of 102, rapid strep throat is positive, but he tells you that he had a rash after taking penicillin a few years ago. So what would you ask him? So it's important to ask whether he had a remote history of a reaction or whether it is a recent reaction, because most of the remote reactions and which are benign or mild are less likely to be severe enough to cause a reaction at present. So most of the time when we reintroduce, they are able to tolerate it. And that's the reason it's important to know whether it was a remote reaction or a recent reaction. Whether it was immediate or delayed. If it is an immediate reaction, it's IgE-mediated hives, and skin testing can be helpful. Whether if it's a delayed reaction, skin testing is less likely to help. We cannot desensitize these patients. Hence, it's important to know, understand, and document these reactions. And the type of rash. Most of the time, patients would not know what kind of rashes that they had. And most people say, I don't know, there was some kind of a rash, or they give vague answers, but there are few leading questions that can help you understand whether it was an immediate or delayed or severe, or whether only systemic symptoms and things like that. So I'm not going into details here because the next two slides will talk a little bit on immediate and delayed reactions. And it's also important to know whether they had any mucous membrane involved, because severe cutaneous drug reactions like SJS and TN and DRESS syndromes do involve mucous membranes, and they can have severe complications, and whether any systemic symptoms. So if a patient had hives along with any type of systemic symptoms, it indicates anaphylaxis, hence it's important to know. It's also very important to understand if they received any type of penicillin in the recent past. So it's a common scenario in my clinic where they're ready for penicillin skin testing. And when I ask them, have you taken amoxicillin or penicillins in the recent past? They say, yeah, I went to my dentist and a few weeks ago I received amoxicillin. I didn't have any issues. This means that they're not allergic to penicillins anymore, and they are safely able to take penicillin antibiotic or the antibiotic that they recently received. They don't need testing. So it's very, very important to ask them these questions. So quickly on immediate IgE-mediated reactions. So these occur within 30 minutes to 6 hours. The common symptoms are hives or urticaria, angioedema, respiratory symptoms, which include bronchospasm, cough or dyspnea, any type of GI symptoms, which include nausea, vomiting, diarrhea, and abdominal pain. It's important to know that more than 90% will have some type of cutaneous signs. You may come across in your clinical practice about a patient complaining of a subjective shortness of breath a few hours after taking medication. Most of the time, they're not true hypersensitivity reactions, because more than 90% of the time, it's associated with some type of rash or cutaneous symptoms. Hives can also occur a few days after taking an antibiotic or a medication. Hence, it's important to know, even if they present after a few days, they're not necessarily delayed T-cell mediated reactions. They can still be Ig mediated. And skin testing is only helpful in IG-mediated reactions and not in other types. So these are the common scenarios that we come across in clinic. The patient would say, I was covered in hives within a few minutes. That indicates an IG-mediated reaction. I had a facial redness and lips got swollen within few hours. My rash resolved after Benadryl. This is a very important piece of information. A rash that resolves quickly with Benadryl or antihistamines is likely to be IG-mediated hive type of a reaction. And they can also say they had redness all over the body, and their throat was starting to close, which indicates angioedema and anaphylaxis. If they had trouble breathing, and if they had dizziness or fainting or any hypotension or any other systemic symptoms. And rash quickly resolving after stopping a medication is also an indication of a hive type of reaction, because most of the time maculopapular reactions would last for 7 to 10 days. They wouldn't quickly resolve. Coming to maculopapular delayed type of reactions, these are the most common type of reactions. They can start within 6 hours and may last up to 7 to 10 days. These are non-IG mediated reactions. They're T-cell mediated. Most of the time they're benign, minor. They can begin with erythema, fine papules, itchy or non-itchy, or they could have burning. It's variable. Usually begins on the trunk. It spreads to the extremities. It has that centrifugal nature, and it's typically symmetric, and it resolves with skin peeling. This is one of the important features of delayed maculopapular reactions, where you see skin peeling, which you don't see with hives or angioedema. So the common scenarios are rash that appeared all over after 4 days of starting a medication. The rash lasted for 7 to 10 days, did not respond to Benadryl, or they might have needed prednisone to clear the rash, or there was a skin peeling type of a reaction. When I was a fellow, I was called for a consult, and a patient was not in a position to give me good history, and family members were not there, and I forgot, or I didn't realize that I had to ask skin peeling, whether there was any skin peeling. The patient told me that she had a rash and it resolved, and we challenged her. We didn't challenge her. We tried to desensitize with the cephalosporin. The next day, she was covered in a rash head to toe, which was a maculopapular reaction, and she went on to develop DRESS syndrome. So when I went back and checked with the family, they were able to say that she had skin peeling after a few days of taking that medication initially, and that piece of information is extremely important because you cannot desensitize T-cell mediated delayed reactions. So depending on how mild or severe was the initial reaction, you may choose to challenge, but desensitizations do not work in this case. So the other type of reactions are severe cutaneous adverse reactions, commonly called as SCARs. It's very, very important to promptly recognize these reactions, treat and document, as these can have serious consequences. These are SJS, TN, Stevens-Johnson syndrome, and toxic epidermal necrolysis, and DRESS syndrome, which is drug rash with eosinophilia and systemic symptoms. So SJS-TN, the latent period varies between 4 days to 28 days. They can be preceded by a prodrome of fever, malaise, and non-productive cough and stinging in the eyes and sore throat. They are often confused with URI. They rapidly progress to an exanthem of macules and targetoid lesions and epidermal detachment, bullae, and erosive mucositis. It can have disastrous long-term complications. The hallmark feature of SJS-TN is the mucosal involvement, which is present in more than 80% of the cases, which could be oral, the most commonly oral, followed by ocular and genital lesions. So coming to DRESS syndrome, this is also considered as a severe cutaneous reaction, as this can involve various organs. I've had really bad cases of DRESS syndrome. Recently saw a 25-year-old patient who took Bactrim for some kind of an abscess for a few days, and after 13 or 14 days, she developed a rash that looks like this and facial puffiness, and she had myocarditis that was secondary to eosinophilic infiltration, DRESS syndrome, and she had a cardiac arrest. Luckily, she survived, but because of ischemic complications, she doesn't have, her gut had to be partly resected, and it's a mess. So it's very, very important to promptly recognize DRESS syndrome. It typically happens after 2 to 3 weeks of starting the medication. If after taking a medicine, if the reaction happens within 1 to 2 days, it's very less likely to be a DRESS syndrome related to that particular medication. They can also have fever and edema. It's not like big lip swelling that you see with angioedema. It's more of a facial puffiness. They can also have lymphadenopathy, leukocytosis, eosinophilia, or atypical lymphocytosis. And organ involvement is commonly seen in DRESS syndrome. So when do you differentiate? When do you say whether it's a benign drug exanthem versus a DRESS syndrome? When you have a patient who has a maculopapular reaction where more than 50% of the body surface area is covered and you see severe edema and skin infiltration, I would still consider this as a severe drug hypersensitivity, even though there is no organ involvement, and stay away from the medication as opposed to mild spots here and there and a minor maculopapular reaction. Coming to specific antibiotic allergies, the most common antimicrobial allergy that we see is penicillins, followed by sulfonamides and macrolides. And today we'll mostly be talking about penicillins and cephalosporins. So penicillins, as you all know, 2 major classes and 4 minor classes, and 2 major classes are penicillins and cephalosporins that we will be talking about today. So penicillin allergy is reported in around 10% of the population, and most of the time, more than 90% are eventually able to tolerate. This is based on large-scale skin test studies and oral challenges, and anaphylaxis is seen in 1 in 1,000, severe cutaneous reactions 1 in 10,000, and fatal anaphylactic or fatal reactions are extremely common with oral penicillins. So what we do when we see a patient with a penicillin allergy or a history of immediate hypersensitivity, we do skin testing. The negative predictive value is pretty good. It's more than 95%, roughly about 97%. Positive predictive value is low. Hence, not all positive skin tests can be considered as an allergic patient. And when we see a negative skin testing, we typically do amoxicillin oral challenge to confirm. Only if they tolerate, they are considered as not allergic. There is also penicillin serum IgE that's available that's not regularly used in clinical practice. When it is positive, it is helpful, but it is very low. It has very low sensitivity, hence we don't do it commonly. But it can be helpful in patients with a recent anaphylaxis. If a patient had an anaphylactic reaction within the last 4 to 6 weeks, we tend to stay away from skin testing because it can be falsely negative theoretically. So not all positives are positives, as we just discussed. Hence, recently people have been asking if we really need to do skin testing in all patients with history of allergic reactions to penicillins, because we have, there is variability in testing and interpretation, and the testing can be falsely positive. And oral challenges have been done in low positives and versus negative skin test patients, and there was no difference in prevalence of adverse reaction when you do the oral challenge in weakly positive versus negative test. So one of the important goals of drug allergy evaluation is delabeling to aid the use of first-line antibiotics and to prevent any side effects that are related to the second-line agents. Hence, I would like to look at the delabeling in 3 different ways. 1, delabeling just by history. So it's all our responsibility to ask what exactly happened initially with the patient. If there was a minor subjective symptom like a headache or some type of mild GI upset without any other signs of hypersensitivity reaction, it's important to delabel them or consider delabeling if you're comfortable. And delabeling by skin testing followed by oral challenge, which is commonly done based on guidelines. And delabeling by oral challenge without a skin testing. So multiple studies recently have shown that oral challenges without skin testing can be safely performed in low-risk patients. Let me present a case. So here is a 50-year-old male with a past medical history of HIV and diabetes, presents with a penile lesion. Diagnosed with early syphilis, has a history of allergies to penicillin, doxycycline, ciprofloxacin, ibuprofen, and cetirizine that we commonly see in clinical practice, a patient with multiple drug allergies. Allergy history, penicillin. My mother told me that I'm allergic to penicillin when I was a child, and I don't know what happened. Doxycycline, I became pretty sick with fever and rash. After a few days, I had to be hospitalized. Cipro, I had diarrhea. So what would you do? Refer him for penicillin skin test while you treat her with an alternative antibiotic. Can consider test dose of amoxicillin or penicillin and observe to see if he can tolerate. can give doxycycline since his history of fever is less likely to be hypersensitivity. So we can do a penicillin skin test while you treat her with an alternative antibiotic. It's commonly done in clinical practice. But in this patient, as you see, the history is remote and he didn't know what exactly happened. And most of the time, studies have shown that when you re-challenge these patients with the unknown history is typically considered as a low risk, they can tolerate the penicillin without any issue. So hence, I would choose the option 2. Can you give doxycycline since his history of fever is less likely to be hypersensitivity? No, because this guy had fever and rash and he was pretty sick to be hospitalized. So that could be a DRESS syndrome. So I wouldn't give doxycycline here. So the point is, based on history, if you recognize that this patient is low risk, I think we should be considering oral challenges or without skin testing. If you're not comfortable, you can always talk to an allergist, page an allergist or me, and quote me to challenge this patient, but we should all be considering. So again, based on extensive data on safety of oral challenges in low-risk patients with certain features, the experts came with the following questionnaire for evaluating patients with penicillin allergies without skin testing. Did this patient have a reaction in the last year? Or did he have any systemic symptoms other than rash or any other skin symptoms, or severe anaphylaxis, or this patient had any type of skin ulceration or sloughing that is concerning for SJS or TN, or any organ-related dysfunction or failure. If the patient didn't have any of these features, they are considered low risk. And studies have shown that irrespective of a positive or a negative skin testing, you can safely challenge them, and most people do okay. And why do we really need to do direct oral challenges? Because there are limitations of skin testing in low-risk patients, as I mentioned, and only minority of patients with penicillin allergy are truly allergic, and risk of anaphylaxis is low with oral amoxicillin, and skin testing is not available everywhere. And history has shown to be an effective way of identifying low-risk patients, and multiple studies have shown that the chances of having an immediate reaction with a direct challenge in low-risk patients is 1 to 3% of immediate rash, and 3 to 6% patients can have delayed non-severe rash, and none of these patients had any systemic reactions. So overall, based on the studies, these are the questions which you can use to rule out the high-risk cases where you should not be challenging, or they need further evaluation in allergy clinic. So it can be considered in patients who did not have a reaction in the last 12 months, any benign rash, just the minor GI symptoms, headaches, or benign somatic symptoms, or unknown history, and if they didn't have any features suggestive of any other systemic symptoms or SJS or TN or organ dysfunction. Coming to cephalosporin allergy, cephalosporin can lead to any type of allergic reactions. There could be minor rash or anaphylaxis or severe cutaneous drug reactions. The rate of anaphylaxis is low, as you can see here, and cephalexin is the most common cephalosporin involved, and in perioperative setups, cefazolin is the most common one. Previously, it was thought that the rate of cross-reactivity with penicillins is 10%. I think this was because of contamination of early generation cephalosporins by penicillins in the olden days, but recent studies have shown that the immunologic cross-reactivity with penicillins is only around 2%. This is because the beta-lactam ring is not the major antigenic determinant. The cross-reactivity may be higher with penicillins with similar arch chain rather than the actual beta-lactam ring. For example, amoxicillin has cross-reactivity with cefadroxil and ampicillin with cephalexin because of the common R1 chain. So here is the list of cephalosporin based on their R chain cross-reactivity. Whenever there is a history of allergic reaction to a cephalosporin, we test and do the oral challenge with a cephalosporin that does not share the common R chain, depending on what the history is. Here's a 45-year-old male with HIV with gonorrhea, needs ceftriaxone, but patient has a history of generalized hives after a procedure 3 years ago, which was presumed secondary to cefazolin. Cefazolin doesn't cross-react with ceftriaxone. That's the clue. What do? Desensitize for ceftriaxone. Avoid all cephalosporins. Can consider skin testing with ceftriaxone. If negative, can do graded challenge. So you can consider skin testing with ceftriaxone. This patient, going back to the case, this patient had history of generalized hives after a procedure 3 years ago, maybe an true IG-mediated reaction to Cephalosporin. If you're truly concerned, you can send this patient for skin testing with ceftriaxone. But it's also important to know that the skin testing for cephalosporins is not standardized like penicillin. So if it is negative, can I confidently say it's truly negative? No. But based on the history, if there was no high-risk features, we sometimes choose to simply challenge with ceftriaxone without any skin testing. But sometimes we do the skin testing just to rule out. If it is positive, it is helpful not to challenge them. If it is negative, it suggests that he may not have the IG-mediated hypersensitivity with the ceftriaxone, and we challenge them. So again, cephalosporin administration to a patient with a history of allergy to cephalosporin. Simply do the graded challenge with a cephalosporin that does not have the same R chain, or do the skin test. If it is negative, you can do the graded challenge. If it is positive, you can either give an alternate drug or desensitize to the cephalosporin. Here is a 36-year-old with gonorrhea. He reports history of hives within 30 minutes of taking penicillin in about 5 years ago. He denied any systemic symptoms. What's the best choice here? So here we have a patient with a history of hives within 30 minutes of taking penicillin, probably an IG-mediated immediate hypersensitivity reaction to penicillin about 5 years ago. No systemic symptoms. Can use third-generation cephalosporin here. Second option would be recommend avoiding penicillins and cephalosporins. Third option would be to treat him with azithromycin and treat with amoxicillin since penicillins do not cross-react with aminopenicillins. So the answer would be you can use a third-generation cephalosporin, ceftriaxone. I'll tell you in a minute why I chose this. The second option, recommend avoiding penicillins and cephalosporins. As we saw, the chance of cross-reactivity between penicillins and cephalosporins is low, and there is no cross-reactivity. The major part of the cross-reactivity is through the R chains and not with the beta-lactams. Hence, the second option would not be appropriate. Treat him with alternatives, which you can always do, but it's important to choose the first-line antibiotics and delabel the allergies whenever possible. And can you treat this patient with amoxicillins and penicillins do not cross-react with aminopenicillins? First of all, gonorrhea is not treated with amoxicillin, but this was chosen for a different case, and I just left it there. So amoxicillin and penicillins are highly cross-reactive, hence you should not be treating patients with penicillin allergy with amoxicillin. So the best option here would be to choose third-generation cephalosporin. So cross-reactivity may be higher in penicillins with the first-generation cephalosporins, and cross-reactivity is considered negligible with second or third-generation cephalosporins. And it's generally considered that C. diff is more common than allergic reactions in patients with history of penicillin allergy than having a reaction to cephalosporins based on multiple studies. And penicillin allergy testing is not really useful in evaluating risk of cephalosporin-associated reactions. And skin testing is not validated with cephalosporin allergies. So we simply choose an alternative cephalosporin, which ideally does not share the cross chain, the side chain. Or if this patient had a reaction to penicillin, it's okay to use a second or third generation cephalosporin based on multiple studies. What if giving penicillin in patients with cephalosporin allergies? So if there was a history of anaphylaxis to a first or second generation cephalosporin, we recommend skin testing with penicillin before challenge. As I said, the chances of cross-reactivity with cephalosporins with penicillins is higher with first or second generation cephalosporin because of the common R chain. However, with the third or fourth generation cephalosporins, the chance of cross-reactivity is low. Hence, if a patient has a history of anaphylactic reactions to third or fourth generation cephalosporins, we can challenge them with penicillins, either amoxicillin or any other penicillins. Another question, here's a 38-year-old patient with HIV with optic neuritis, is diagnosed with neurosyphilis, reports history of hives all over his body and wheezing 60 minutes after amoxicillin a year ago during a dental procedure. His culture is sensitive to. Consider 1 to 2 step challenge with amoxicillin to prove the penicillin allergy. Choose alternative antibiotic or desensitize him for IV penicillin. So this patient has neurosyphilis who needs penicillin, but This patient had hives all over and wheezing in the last year. This is considered a high-risk reaction, likely an immediate IgE-mediated hypersensitivity, looks like anaphylaxis. Hence, it's not a good choice to challenge him with penicillin because he might have a reaction. You cannot choose an alternative antibiotic here, so you need to desensitize him for IV penicillin. Yes, you can skin test him with penicillins, but in such a high-risk patient, what if the skin testing is falsely negative? Then he might end up having an allergic reaction. Then hence I wouldn't trust the skin test. I would directly desensitize, since this is anyways a high-risk reaction in the last year. So what are the key points in evaluating and managing any drug allergy? So documentation of symptoms and temporality is extremely important. We can do skin testing if appropriate, if the history is suggestive of an immediate IgE-mediated hypersensitivity, or even if the rash was unclear or delayed, we sometimes do this to rule out the possibility of IgE sensitivity. We can consider direct oral challenge or test dose in low-risk patients, given the extensive data on safety of during direct challenges. Although these things are done in allergy clinics for the most part, but there are also centers like MGH and Vanderbilt and UCSF and many other institutions. They are coming up with protocols and guidelines to help people choose the right antibiotic and help them do the direct challenges or test dose themselves without the need for skin testing. And if you think the patient is likely to be allergic, please refer them for desensitization.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.